Thanks very much for the wonderful introduction. It's a pleasure to be here. So with the translator, just so I see you, so when I am going too fast. Okay, so just raise your hand. I'll try to, I tend to talk fast, so I'll try to slow it down, but just let me know and don't hesitate. So I'm going to talk about the brain. So as Kenneth indicated, I do a lot of different kinds of things. I just love the work that I do here in Toronto and with the Ontario HIV Treatment Network. But I did train as a neuropsychologist and to understand the brain. So that's what I'm going to talk about today. How many of you had breakfast this morning? How many of you had blueberries and oatmeal and strawberries and all the... Did you have a good breakfast this morning? So you'll see in my talk today, my slides are really a backdrop for what I'm going to talk about. And so one of the first things, let's see if I can get this to work, whatever is good for your heart is good for your brain. So that starts in the morning with our breakfast. And our nutrition is very, very important for our brain. We're learning every day how important the things are that keep our brain healthy. Working in a hospital, so I work at St. Michael's Hospital, we often think of everything below our neck. And I'm here to say that there's something that we should pay attention to. And so, you know, as I go through my talk, I'm going to be really emphasizing the things that we think as we're growing up, we learn about that are good for our health. There's now so much data supporting these things, like nutrition for our brains. And part of it is actually how we keep healthy our vasculature, our blood system. So, you know, the more that we exercise and do all these things, you'll hear me talk about that, the better it is for our brain. Okay? Now, everybody has a lifestyle. So this is a picture. This is a friend of mine, Evan Collins, who I was just meeting with. This is a woman smoking a cigar, kind of hanging out, and we all have a lifestyle. We all have different things that we like to do. Some of them are good for us, and some of them, you know, are not so good for us. When it comes to the brain, there are certain things that are, again, good for your brain and not so good for your brain. So part of my talk today is to really accentuate what those things are. This is another it's a cartoon, and this is a doctor and there's a patient, and it says, no caffeine, no sugar, no wine, no cheese, no chocolate, no pizza, no ice cream, no candy, no cookies, no fat, no spicy foods, and by the way, stay out of the sun. So you hear these messages, and my message today isn't to do, you know, it's all about moderation, as you know. It's all about, you know, thinking about things that are good for you, and sometimes you got to have a cheeseburger or fries and a Coke, but you just don't want to have that every day, right? So I'm going to get a little bit context for so Kenneth introduced the term hand. It's not my hand, but we've given this term now, HIV-associated neurocognitive disorders. It's a big word, or 4 words, that basically mean there's 3 things that can happen. So HIV can affect all the organs of the body, and it can affect the brain. And 3 things can happen. One, which is really kind of the extreme, that doesn't happen very often, is called, you've heard the word dementia. So dementia is something that everybody gets concerned about, and I run a clinic at the hospital, and people are often, yesterday I saw, I think 4 or 5 people, and one of them was concerned, these are all people living with HIV, and one of them was concerned that, well, my dad had Alzheimer's, and his brother did, and, you know, I'm concerned about my own cognition. So we do tests that can help us understand whether somebody has hand or not. And then I can also, as a clinician, help to, you know, sit down with people and say, you know, what's your risk for Alzheimer's or not? What I can tell you right now is that there doesn't seem to be a relationship between if somebody has HIV and developing Alzheimer's. That Alzheimer's has its own kind of, you know, that's sort of independent of what happens with HIV. and we've been studying this for 20 years, and I have colleagues around the world. We don't think that if there's a cognitive problem in HIV that puts you at risk for developing this. The risks are probably independent. Having said that, a lot of people aren't, as we study people into old age, we'll learn more about it, but it isn't something that really is very striking. So the three things, so that's the extreme. Now, let me give us some numbers to dementia. So before combination therapy was available, the triple cocktail, right, it happened in people who were advanced with HIV. And so it happened in about 7 to 10% of people who had advanced AIDS. Now, people today don't progress to AIDS anymore. And in fact, the numbers are probably 2 or 3% of people all living with HIV. So the numbers for dementia have gone down considerably with treatment. What hasn't changed, or what's more common, is a milder condition called mild neurocognitive disorder. And basically it's like, you see in the papers about concussions and or hockey players who hit their heads too much, or the football players. And those are brain injuries. HIV can cause a brain injury, but it can often be mild. And so we're going to talk about that. So that's common. It probably happens in 30 to 40% of people at some point living with HIV will develop some cognitive problem, but it is manageable. And like any kind of brain injury, people learn how to adjust to it and deal with it. And so that's what I want to talk with you about today. So right up front, I want to say dementia, because it's really important it's something that can happen. It doesn't happen very often. I don't see it very much anymore. But there's the milder things, and that's what we're really trying to really study much more intensively to see what we can do to help people. Okay? So these are the kinds of things. So when I see people, now I'm going to talk about what people say. So what does people say when they come to see me, and what's the experience of a person that has a cognitive problem, and what do they relate to? So, whoops. So when I see somebody, they'll say things like this: I'm forgetful. My short-term memory is not very good. I misplace things. This is common. I walk into a room and forget what I went to get. I lost my keys. Where did my keys go? I forget my appointments. There's other things like what we refer to as word-finding difficulties. The words on the tip of my tongue. I have trouble remembering people's names. Now, I point these things out. These happen in HIV, but they happen as well as we get older. So this is what makes it complicated. And at some point during this talk, I'm going to have a word-finding problem, and I'm going to get stuck. It happens. It's part of life, and it happens more as we get older. So this is what makes it more complicated, that it can happen in HIV, but it happens just normally as we get older. Okay? These are some other things. The other thing is concentration is pretty common. Can't focus. Feel like I'm more in a fog, or people talk about sometimes brain fog. People talk about I can't do many things at once anymore. What HIV can do to the brain as well is slow it down. So as you know, when we're 20 years old, we can run so fast with a 100-meter dash, and when we're 40, we can't run as fast. Well, our brain is the same way. It slows down as we get older. So again, both HIV can do this, and so can aging. Okay? So what's important to realize is that the things that I just talked about on the left happen as well with aging. And that's what makes this complicated, and what makes it sort of a bit more of something where you need people to help distinguish what's what and what isn't. There's some things that don't happen with aging, don't happen with HIV. So, language usually doesn't change at all. There's things that other kind of cognitive functions aren't affected by HIV. So I was mentioning just the four. So it's slowing, the concentration, and memory, and the word finding. Those are the pretty common things that happen. And I don't know if you noticed, but coming back to concussions, they're the same kinds of things when you have if you've ever had a mild head injury or a concussion, hit your head, that you have trouble remembering, have trouble concentrating, you slow down. So it's a lot like that. And with HIV, we don't talk about it as being a brain injury, but it really is. And I think it's really important for us to think about that, because if it's an injury, we can then, it isn't just something because somebody isn't trying hard enough. It's something's happening to the brain, just like HIV can cause problems with the heart, with the kidneys, with the liver, and so on. This is a busy slide, but we've done a lot of work and research to figure out, well, if somebody has a mild problem with cognition and HIV, what does it lead to in a person's day-to-day functioning? Well, you can imagine that if somebody has trouble with remembering and concentrating, it's going to affect their job, and it does. It may affect people's ability to manage medications. We know that, we've seen that. It can also affect people's socialization. So if you're having trouble remembering or paying attention, you may not come out to an event like this or go to a party because it's too busy, or you have trouble keeping track of conversations. And so even a mild problem with the brain can lead to people not going to things that are good for their socialization. Does that make sense?
Makes a lot of sense.
And obviously, if these things you're not doing the things that are part of normal life, it's going to affect a person's quality of life. So that's pretty obvious, but we've been able to show how much it does and how important that is to focus on. Now, some people ask me, well, so Dr. Rourke, and when I started at Wellesley, people said, well, this is a mild problem, Sean, so we shouldn't have to worry about it. I said, well, you know what? Even a mild problem can have a significant effect on a person's sense of self, their sense of confidence, right? If you're not as sharp because your brain's been affected, you may not do the things, or you may not feel as confident or feel that you have that mastery to do the things you want to do, right? And so I personally, as a psychologist, I think it's very important to say, well, you know what? It's not because you're not trying hard enough, it's because you've had a brain injury, right? And so people would say to me, well, I'm not working, so does it matter? And it matters a lot, right? It matters because, people want to go out and do things, and it affects, when I go to the grocery store and forget things, or I want to go to this party, or I want to do this, right? So even these mild things can be very significant. It all depends on the person, right? It all depends on what's important in their lives. So I always have to tell I think the doctors believe this now, or more so than they did before. But 20 years ago, they said, well, don't worry about it. You're just getting people on medications, and that'll do it. Well, I think it's really important to recognize the importance of the individual. This is just a slide for me. So when I came to the hospital, I said, well, I have these tests that I use to, you sit down, you come into the hospital, and we give these neuropsychological tests. And one of the things that I was trying to figure out was, could I ask questions to a person and diagnose that problem? And could I teach other people to be able to do that? So for example, I could ask you, if I asked you a certain way about your memory and concentration and word finding, and your answers to that might help me diagnose hand. Turns out I need to do tests like you do for any blood, like you have a medical test, I need my cognitive tests. And why that is it's a bit complex, but part of it is that, or what seems to influence that, is how we feel. So if you're having a bad day and you're not feeling good, physically or emotionally or spiritually, you're going to report cognitive problems. Not because there's anything wrong with your brain, but because you're having a bad day. Right? Say, well, yeah, I'm forgetful, I'm losing this, but does that mean you have a brain problem? It might just mean, you know what, I'm depressed today, I'm feeling really crappy, I have fatigue, and that's what it is. And so part of my job is to be able to separate those things out. And half the people I see think that there's a problem, but when I test them and say, your brain's fine, you're depressed. Or, you know what, there's a lot of stress in your life right now, and that's causing you to feel like you're just overwhelmed, and you're forgetting things because you're overwhelmed. And so it's important, this is really, was for me, seeing if we could try to figure that out. And what we know is how you feel really influences. So today, I don't want you to walk home tomorrow and you say, well, I had a bad day, there's something wrong with my brain. It's important to say, well, what's going on in my life, And it's really over time, if something continues to happen, then, you know, when you're feeling good and physically okay, that's the time to sort of think more that, well, there may be something going on. What's really interesting is that in this whole area, I've been working for 20 years, we've just started to do work to understand what's the experience of people living with HIV who have hand. So I have some colleagues that work with me to interview people and understand what their experiences are about living with cognitive problems. And I can tell you that we're just beginning to understand what it really means in a day-to-day life. Like I gave you some examples a minute ago, but really, and we need to understand, if we're going to help people more, I think we have to understand more of this lived experience much better. And I have a colleague at the OHTN who's just put in for a grant to do more of this work, because I think it's really important on the rehabilitation side to understand what an individual's experience is, how they cope with this. So just to let you know that there's still a lot to be done. Now, this is something I want to show you here as a graph. You can see this line that goes up. So we kind of peak when we're 20 years old. So when we look at speed, I was telling you about sort of running, we have a mental speed. And that pretty much peaks out when you're 20, and it goes down and down and down and down as we get older. And that's just normal, right? So we don't, and again, we don't run as fast, and our brain doesn't process as quickly. So this is something that's important because there's a lot of emphasis on HIV about accelerated aging. You hear about this term. And that's partly what we're dealing with. Is it just normal aging, or is it something different than that? So, but I want to show you that the expectation is when you're 50, you don't expect to do as well as a 20-year-old. And that's speed, or you don't pick up, your memory isn't as good, and so on, and that's just normal, right? Here's another. We often talk about multitasking. So, you know, if you sort of talk, and at a certain point, if I'm jumping and moving my hands and chewing gum, I can't do all those things at the same time. I'm multitasking. And at a certain point, I'll fall on my face, right? As we get older, we can't do 3 or 4, 5 things at once. We can do only 2 or 3. And again, that's just normal. But HIV can affect this, and that's what my job is, to figure out what can happen. Probably like this, and that's difference, right? That's probably what HIV. It's a 10-20% change, but not a huge departure. Right? There's individual variability, but I should actually add that. Here's what we expect, and it may be that there's a lot of things that happen when we're in between our 40 and 50 years of age. So you can do a lot of things to the body and brain, but at a certain point, you should really change that. So before I did HIV work, I did work in alcohol and in people who drank a lot for a long period of time. And you can drink a lot in your 20s and 30s and 40s, but there's a certain point where if you don't want to do damage to your brain, that can do damage to the brain. But at a certain point, if you stop, you can fully recover. But as you get older, in the 50s and 60s, the recovery and you stop is not as complete. So there's a certain amount of reserve that we have, and this is true for probably all of our organs of our body. And you can eat all the cheeseburgers and not get any sleep and smoke, and at a certain point though, your body won't recover from them. And so there's a certain reserve that is intelligence though is something that kind of goes along with speed. So this is true for the moms in the room and some of the dads perhaps, and if you experience this when you're a kid, the faster kids are usually going to be the ones who are the smarter ones, right? And so there's a certain thing that intelligence and speed go together, but it's a complex answer. But I guess what's important is that you're getting into the question of how much reserve or how much potential, right? So what we do know, and this is important from the standpoint of how the brain can be affected and how much you recover. There's never a time to stop thinking about how much. We used to be this adage that you lose these brain cells, but you don't get them back. It's not true. The brain recovers. and it forms new connections. And so there's never a time not to think that you can't make it better. And so I think so if you have more, and maybe intelligence, and the more you do earlier in life, the more you have reserve, right? And this is true for humans, it's true for animals. So you can put an animal in a very enriched environment, and one that's deprived, that doesn't get the stimulation. The one that has the stimulation is going to just have these stronger networks and more resilience. It's true for a lot of things in life. You stimulate things and people, and you build reserve. You don't nurture, and you don't get that. It's not as strong, right? So that partly answers your question. But I think from the standpoint of the brain and HIV and anything else, there's never a time not to stop and think what you can do to improve it. And that's the thing that's really important. So today you came to this lecture, but most days we go through our lives doing about 90% of the things that are the same, right? Get up and have breakfast, brush our teeth with the same way. Who's ever tried to brush your teeth with the other hand? What happens? You try, and then you hit, you're this way and this way, but if everybody went home tonight and started to brush your teeth with the other hand, you'd hit all the sides of your mouth, but the next day it'll get better, the next day get better, and you'd learn it. And at a certain point, you'd be just as good with your other hand as you are with your right, if you're right-handed. So, and that's your brain building new connections. So never a time to stop. This is more of a lot of my slides are like this, just a backdrop of some work. So this is a study by some people actually I train with. There's a thing called accelerated aging. And so what we're seeing is that what HIV can do is just make things age quicker, kind of that line. And sometimes the brains can look 5, 10, or 15 years older. Not everyone, but that's what it does. And so it often looks like a person who is a 15 or 10 or a decade or 15 years older. And that's teaching us something about the virus is a very significant virus, and there's lots of treatments that are very significant too. So there's lots of things that go along with that, right? So this is what we're trying to understand much better. But that's the accelerated aging that you hear about. The question of heart or combination therapy. So what have we learned? So around 95, when combination therapy, dramatic changes in survival, incredible. How has it changed hand? As I said, it's made it better we don't see dementia as much anymore, but we see these milder conditions just as commonly as before. So the medications are great for a lot of things, but they're not going to solve the problem with the mild problems. And so what that means, it's a lot like heart disease. So with heart disease, as you get older, you can develop heart disease. And sometimes the medications, blood pressure and lipid lowering are helpful. Sometimes that's not enough. You got to exercise, you got to watch your diet. And so it's just like that for HIV, I think, in the brain. Is that we got to think about there's no magic pill. Combination therapy is very important for HIV, but for the milder things that happen, we got to think more health promotion and health management. This is the paper that was in 2007 that started this thing called HAND. So in medical practice, we take a long time to change things. Now we've known this for a long time, but this was a group of people that got together and developed out those three things that I was telling you about. And so if we look now, what's I think exciting is that since 2007, if you look in the literature, there's just you can see the exponential growth in the work that's going on in the brain. So we're learning a lot, and we're going to learn a lot more to help people. And I think this has kind of put our finger on it, because before then, I think it was dementia and this kind of other thing. Now we have HAND. At least this gives us something to have a conversation about. And I always think that's a good idea. So for me, this was an important paper in the evolution of the brain problems that happen. Now, just to get a bit technical, and then a lot of my other stuff is going to go away from that now, but I talked about dementia. That's over here. That's where you have cognitive impairment. That's significant, very significant, and where the functional impairments are moderate or severe. You don't need a neuropsychologist to help diagnose dementia. A person may or may not know it, but certainly the people around them and their doctors will, right? It's the two other things. I talked about this mild neurocognitive disorder. So this is when there's mild cognitive impairment and some functional impairment. So it affects a person's work or their ability to manage different life things, social relationship things. But I didn't tell you yet about this other one. And it's got this fancy name. It's called asymptomatic neuropsychological impairment. So what does that mean? Well, there is cognitive impairment that's at least mild, same as this one, but functionally there's no difference, or functionally there's no problems. So I'll use my test and I'll notice that there's a problem, but the person says, well, I haven't noticed it yet. And it's kind of like blood pressure. So you know how blood pressure is. Sometimes you kind of feel, my blood pressure's high, like I'm really stressed. And it may be. But oftentimes what happens, that's why doctors take it every time you go in, is because it's one of those silent things, that your blood pressure may be high and you may not know it. Sure. Right? And knowing it is important, because then to manage that, that's important, right? So this is like, so for this, it may be, it's an early problem that may develop more into this that may affect a person's life in a more significant way as it evolves. And so there's a lot of there's controversy about this. Some HIV doctors say, well, why, if the person's not noticing a problem, maybe it isn't. And I think there's another group of people saying, well, we think there's these impairments, we think it's important to pay attention to. And so the research is going to tell us how important this third category is. My feeling is probably important. And it's kind of like that high blood pressure example, that if we can, because it's not only detecting it early, maybe there's something we can do about it when it's earlier in its development than when it's later. And this is the thing about what happens with brain problems, is that, and I'm not a neurologist, but what happens is when there's a neurological problem, it's usually very advanced. And at that point, sometimes there's not a lot you can do about things. So I think the more that we understand sort of what happens earlier on, we may be able to help people modify that so that they can actually not have it develop. Does that make sense?
That makes sense.
Okay. Remember those categories I introduced you to? So remember I told you that dementia doesn't happen very often? So in Ontario, it's about 3%. So it's a very small number of people. This is about 1,000 people that we've seen. So mild condition happens in about 15% of people. So 1 out of 6. Okay? And that asymptomatic group, that one group about the blood pressure that's high but you don't know it, is very high. So that's the one I think that we need to be paying attention to. So these are some real numbers for the 3 conditions of hand here in Ontario. And that's helping us understand, what now to do about it. Okay? Things that we published a paper, I guess it's been about 6 months now. So I'm the only person in Canada that has a clinic for these tests. And so that's kind of unusual when you think about there's a lot of people living with HIV. Why isn't that available? Well, our healthcare system needs to evolve to have more of these available. In the meantime, we're trying to figure out how we can develop screening tests that can then help us understand who might have this problem of hand and who doesn't. So one of my I have a student, her name was Amy Sapersky, worked with me to look at all the literature on all the screen tests that are out there. And the bottom line from this was that the screen tests that we have are very good for detecting dementia, but not very good at detecting these milder problems. And we need to develop better tools. And so I have a grant now from the government where we're developing new tools that we hope will be available very soon in clinics and in doctors' offices and perhaps even online that people could take and then know how they do it in their own homes on a computer or on a tablet, and then go to the doctor and say, well, I think this, it tells me that I may have a problem, maybe I should get this checked out, right? And we hope through this that we'll have these better tools that can help us kind of reach out more, because if I'm the only one doing this, that's not going to work to reach more people, right? If this is a common thing that occurs. So we're working on that too. This is a little bit fancy, but I did want to say that what happens if you talk to people living with HIV who have have had a cognitive problem and go on combination therapy, what happens is the most improvements happen probably within the first 6 or 9 months, and then afterwards they plateau. And that's what we see here. People start, they plateau, and and their improvement gets to a certain point. And that's like any kind of brain recovery, that when you have a concussion, your brain recovers. And you recover the most in the first 6 to 9 months, perhaps up to a year. And then after that, the recovery is a bit slower. And so this is important from the standpoint of, after we get to this point, let's say after 48 weeks, if a person's only got so far, what else can we do, right? If the medications only go so far to help a person, again, it's like cardiovascular disease. So we can treat people with statins, with high blood pressure medications, but then it becomes the things like exercise and the other, diet and so forth that we need to be looking at. And that's what I'm going to be getting to in my talk in the end here. This is just to remind me again about the impact, the importance of our vasculature in cardiovascular disease. That I think that we're not paying enough attention to that, and that from the standpoint of overall managing HIV, but also with the brain. And we're learning a lot as people get older. The more that you keep your vasculature in good shape, the more that you live to old age with your brain in good shape. And it's probably even more important in HIV. And these are studies that just came out in the last 4 or 5 years. And so before that, and so there's now more and more coming out. But I think we've lost some ground that we need to catch up on, that we weren't really paying attention to cardiovascular disease and the brain. And now we need to do that even more work. So, because I believe that really if we can pay attention to these earlier on, we can probably prevent some other things from happening, like the cognitive problems. And so, and what may be one of the drivers here, and nothing against people who smoke, but smoking is a big driver for cardiovascular disease, and it's something we can do something about, right? So, just to say that we're now catching up and we got to do more work, but keeping your heart in good shape is going to be really, really important. Okay, so that's all the technical stuff to kind of lay the foundation. Now we're going to get in to talk about what you can do about it. Okay, so I like these because, again, tomorrow morning, have pineapple and blueberries and strawberries and oatmeal, all those good things that are good for your heart, and get out and exercise. There's a guy at the hospital where I work. His name's Mike Evans. And he's got this great YouTube video called 23 and a half hours. And his message, it's a YouTube, it's about 8 minutes. It's called 23 and a half hours. And basically his message is, do anything you want for 23 and a half hours during the day. For the other half an hour, go and get your heart rate up. Go and have that brisk walk, or that swim, or that bicycle ride, or that stand in one place and just skip rope, or whatever you do. But it's that half an hour a day that's probably the most significant. It's the most significant intervention for health ever. And he does a really nice job. He's got this whiteboard that he walks through, and it's narrated. And he's does it a whiteboard and uses erases it and draws something else. It's called 23 and a half hours. So one of the things, I don't ask people to, when they leave here, to do any homework, but I would encourage you to watch this because it's a great video. 23 and a half hours by Mike Evans. What do you do to maintain your brain health? So I've given a few of these away. Exercise, diet. What else is up there?
Eating healthy.
Eating healthy. Sleep.
Cardio.
Sorry?
Sleep.
Sleep.
Cardio.
Cardio. What else? What about stress? Is stress good for you?
Sometimes.
Sometimes. If it gets you motivated to go and exercise, yes.
Yeah.
What else is good for you?
Sex.
Sex, yeah, that's exercise.
That's exercise. Yeah.
That's releasing stress.
Meditation.
Meditation, definitely.
That's sex.
And meditation, you know, it's interesting. We're doing trials now of meditation cognitive behavioral therapy and how useful that is for cognitive problems. And there's evidence now showing how it changes your brain, so in a good way. So keep on doing that. What else? The cancerous people say don't drink any alcohol. I'm not sure that's the real world. But you know, 1 or 2 glasses of wine, or you know, this is actually good for your heart health. I don't think cancer specialists, you know, because Linda Radnick, who's part of Cancer Care Ontario, just came out a couple of days ago, said no alcohol is good. Well, I don't know, but everybody has to make their own decisions. Talk to your doctor. But what alcohol does do in small doses is it loosens up your blood vessels, right? It's when you drink too much for too long that's a different story. Smoking. So cigarette smoking is actually, you know, something that will affect your brain health. What about this one? Thinking positively. That's a big one. So you can do stuff just with your head. Thinking positive, have positive thoughts, thinking, being optimistic. People who are more optimistic really, you know, report more happiness, but they also it's related to your brain health, right? So in addition to the obvious ones, think positively and remember to keep your brain active. And so in terms of diet, so colleagues here in Toronto up at Baycrest, they do a lot of work with brain health. And there's a book called Mindful that you can get online. I think it costs about $10 or $12. Now, you don't need this book, but there's lots of things out there. But the lentil, the wheat berry salad with mango, you know, it's just being creative with diet. There's a lot of good foods that are really good for your brain. And leafy vegetables, fish, and, you know, watch all those cheeseburgers, right? So anyway, this is just an example. I'm not promoting this one, but it's a good example of something of diet is really, really important for your brain. What about physical exercise? So there's a lot of work now happening showing how much physical exercise is good for your brain. Here in Canada, there's been a study called the Canadian Study on Aging. It's been going on for many, many years. The government has invested $50 million in the next 20 years. And one of the most important things of living into old age, one of the single most predictors, is activity level. And that is, if you're active, you know, you're doing things, that's going to keep you alive for the longest period of time. Now, there's a lot of other things that happen in our lives, but that's a very significant predictor. And you know this, so your parents or grandparents or uncles and aunts, great aunts, those that are most active live longer, right? And so activity level is really important. And you now hear it even to that we shouldn't be sitting for listening to me. We should be getting up and act. But sitting for hours is not good for your vasculature. And so they're saying, well, you should get up and move around. And you know, I mean, I think that's good. But activity level is really, really important. Now, what are we learning from exercise with HIV? There's a couple of studies now from colleagues that I worked with that are showing that physical exercise to the brain is really good in HIV. And people with HIV who exercise have a 50% less likely chance of having cognitive problems. So again, evidence is coming out showing us how important these things are. And this is just you can get really fancy. Now they're putting people and measuring their lung function and lung capacity, and it's getting really kind of interesting because I think we're looking, again, it's like with cardiovascular disease, we're trying to think about, well, the medications have done this much. What else can we do with lifestyle changes that can help keep people healthy? To the point where, and I'm going to show you a bit of some of the brain exercises in a minute, there's some evidence to suggest that, you know when you go for that run or that exercise and you feel really relaxed right after it, you get those endorphins. When those happen, there's these things called neurotrophic factors. That good feeling is actually good for your brain. And it may be, and this is what they're doing in rehabilitation, it may be when people exercise and those are circulating your body, that may be the best time to do cognitive rehab, because those chemicals are secreting and they're forming, and they may have the most chance for forming new connections. And I think this is kind of, for me, it's exciting. And they're, using brain imaging and techniques, we're going to learn more about what are the best conditions to create when people are having problems to make them better. It's kind of what I think is kind of the Rick Hansen approach. Rick Hansen, one of the greatest Canadians, like he just, you see the man in motion. That guy is just, he's done remarkable things because he, has just pushed the envelope for how you should think about rehabilitation for spinal cord injuries, right? And so I think the same is true for now, that there isn't going to be a magic drug. Let's figure out what we can do to create the best recovery for people. So what are the best things that people can do at home or that help with brain health? The important thing is remembering a couple of key things. One is that if it's easy, it's probably not doing anything. It's just like with most things. If you want to exercise, if you want to get in shape, you can't just move your finger on the remote, right? You got to get up and get active, right? But you got to get active in the right way. Doing things that are challenging are important, mentally rewarding. So, everybody finds the right kind of exercise that they like to do. I like to run on a treadmill. My wife likes to run outside. I just that's the best time for me to think. I think, and I don't care if wherever I am, people are doing things. For me, that's fine. She likes to be out in the woods, and running, and they run for an hour, and I can't do that. So everybody's different, right? But find something a place where you can do, again, the mentally rewarding is important as well. Novel or surprising is all these things are, think about something, you have to challenge the brain, you have to make it work. It's like exercise, you gotta sweat, and you gotta get your heart rate up. For your brain, you gotta do the same thing. You can't just read a little bit here, a little bit there. You have to do something challenging. But find what's best for you. That's the real litmus test, right? Whatever works. And this is important. Once you master it, it's not a learning technique, it's not good for your brain anymore, right? So what do I mean by that? So it's like the toothbrush. So once you learn it, the brain's figured out, it wants to move on to something else, right? So if you're doing crossword puzzles, Sudoku, if you just keep on doing the same ones in the same way and reading, you got to do challenging. Move up to the next level or do something a bit more challenging, because you got to stretch the brain a bit, right? To do something that's going to make it work. So remember that. Once you've mastered it, it's not beneficial anymore. It's kind of like, when you run or you do weights, once you get a certain weight, it's like, okay, well, my muscles are good for that. Now I got to raise it in the next level. Put it down one more, right? I've given you some ideas. What else can you do to be mentally challenging? So what are some ideas?
Learning language.
Learning language, yes, definitely. Music. Dancing. Play an instrument.
Learning to play chess.
Learn to play chess, right? So there's so many things that you can do. Dancing, the example, using your other hand, crocheting, all these things. Learning how to play an instrument, it's very good, so be creative is the message. Person has a cognitive problem though. What else can be done? And sometimes it means actually controlling the environment a bit, right? So, if it's distracting, watching TV, listening to your partner, and trying to do this, and that's kind of frustrating, turn the music off or the TV down, right? So minimize distractions. It's a way just to control your environment, right?
Sometimes.
But if you're struggling with, the multitasking, if there's things that are making it, just slow it down. Eliminate one of those variables. Don't try to, we all, with the cars now, and it happens too much, people are driving and, doing their cell phones or doing texting, that's not good. Stop one of those. Using cues, so get into routines. I talked to somebody yesterday who said, I'm missing my meds or I'm missing my appointment, so get into routine. And once you get into routine, your brain will just take over. It loves to do that. It loves to, when we walk across the street, we often, our brains know what to do, right? We don't think about it, but they know you should look both ways and should listen to what's going on, should size things up, right? And we get used to that. So routinize things, get into routine. If you lose your keys, learn how to put them down in the same place, the same time, and leave them there. Don't just put them in your pockets and throw them around. Put them in the same place, and you know what will happen? They'll always be there, right? The other thing is that when we're talking about a person that really has a mild problem, it's a brain injury, there are some important things, and I've mentioned some of these already, but just giving a person a bit of extra time matters a lot. Adjusting your expectations, right? Pacing yourself. This is something that a person told me, said, you may need more time, and you may still have to build in the pieces to compensate, but you can still do it well. So, sometimes we have to give ourselves a break that I can't do it the same as the person beside me, and I just have to do it my own way. I have to give myself some time to do it, right? Okay, the last couple of slides I have are just about some of the data that we're now, the interventions we're doing. So I've told you about how to manage it day to day and talked about diet and different strategies, but now we'll talk about the interventions that we're doing that I think are going to really help us understand what we can do that's going to be helpful. So this is a company called Posit Science in San Francisco, and I should say up front, I don't have any stock in this company. There's all kinds of brain games, Luminosity, you see them. Not all of them have been tested. So brain games are really good, video games. But some are probably better than others. And so we're now testing them, and we're going to start testing them systematically and say, well, this one, we think it works under these conditions. This one may work in these conditions. This one may not be as good. You might have fun doing it, but it may not do anything for hand, right? So as a clinician, as a researcher, I want to make sure that if I can tell somebody, somebody asks me what they can do about hand, I can say, well, I know this might work. It may not work for everyone, but it's shown in a trial to be helpful, right? So that's now what we're doing. And there's what got me to do this is two things. One, there's a woman by the name of Maggie Atkinson who I know well. She's a lawyer, a woman living with HIV here in Toronto. And Maggie came to me one day a number of years ago and said, Sean, my dad's having these cognitive problems, and I have them as well. And I heard about this program and Posit Science, and I said, well, do you think it'll work? And I said, well, I'm not sure. So let me look into it. And so I started to look into it, and I found this study that was done at the Mayo Clinic by colleagues of mine, Glenn Smith, and it was done in aging. And what happened was they gave it to, there was an RCT, a randomized controlled trial, gave a group of 60-year-olds this program for 8 weeks. They did it. They took this computer program, put it on their computers at home, did it for about a half an hour, 45 minutes a day for 8 weeks, and they tested them afterwards, and gave another group an educational control, and then looked at what happened. And what they found was very striking. And those that got this computer test got faster, their memory got better, their symptoms went down. And I thought, wait, this is great. So I went back to Maggie and said, you know what? the kinds of problems we see in HIV are a lot like aging, as we know, and it worked in aging, let's try it. And so she went home and she bought the program for her dad who had had a stroke, and she bought it for herself. And she actually noticed a considerable change in her own performance, and we tested her and so on. So this was the first step, and there was another person, a man, who also did this and got better. And I thought, well, we got to put this to the test. You know, this is just a case study, and let's test this out. So now that's what we've been doing. So actually, kind of hot off the press, I'll be presenting this next week at CAR in St. John's. This is the Canadian Association for HIV Research Conference. And basically, what we were able to show here in this pilot study of about 15 people was that in the blue over here, these are people these are all people living with HIV. This is before and after they got the program. And here's people that were, when we tested them using our neuropsych battery, they were normal. So they were normal before and after. And they didn't change with the intervention, they stayed about the same. The people who had this mild neurocognitive disorder started here, they were doing not as well as the group that was normal, and they improved. And those with dementia who had more significant were worse than the mild group and improved. So that was, for me, encouraging. I wasn't expecting to see that, again, this intervention would actually do that. So this was very encouraging. On this side of the slide, we asked people to rate or to tell us about their cognitive symptoms of what they were experiencing. And as you'd expect, the people who had the more significant forms of HAND had higher levels of symptoms, but everybody went down from 28% to 48%. So people with this intervention were noticing that they were more attentive, they had less memory problems, and they're also doing better on our tests. And so now what we're doing, we've wrote a grant and asking the government to test this now in a larger trial, where we're going to do this with actually another control condition and do brain imaging to now start understanding what's going on. So for me, the question of brain games is encouraging, that this may be one that works. Until we do the study, I can't say for sure, but we have some encouraging results. My colleague Evan Collins, a psychiatrist who does mindfulness-based cognitive behavioral therapy, you're asking about meditation, this mindfulness-based CBT, it's been developed for depression. We ran a couple of groups and have another slide, I don't have in the slide deck, showing that people that did this group therapy actually improve their cognitive ability as well. So these are two treatments now, one in group, one's using a computer program that you can bring home, that offer two options for people that we think are encouraging. So I don't have the answer yet, but I think it makes sense though. So if physical exercise improves our health and our brain health, focused brain exercises might actually be even better, right? I think that visual spatial processing in men is probably a bit different than women, and there may be some evolutionary reasons for that. We all get in this discussion about math skills and science and girls and boys and going to school, and some of it is exposure. I think there are some visual spatial differences. All of these tend to be quite minor though, and in the right environment it's all about, and you know, you learn from at least I think you learn mostly from moms, that everybody has, everybody's unique, right? Strengths and weaknesses, and some people are good at math, and women go on to be lawyers, and men, all these things, right? Yes. The question was, is there any relationship between how long somebody's had HIV and cognitive problems? I think, so there's two elements to that, the answer to that. One is that I can see people who have been living with HIV for 30 years and don't have any cognitive problems whatsoever. And we don't quite understand all of that, why some people develop, some people don't. Part of it is the immune system and what happened to the immune system during, and what risk factors a person has. So people can have HIV for a long time and not have any problems. Cognitive problems can start very early as well, and they can be just subtle. And that's what I think there's a lot of emphasis now on early treatment for a lot of good reasons. There may be some brain benefits to the early treatment, and it comes back to the fogginess, inflammation, or activation. That there's a relationship between CD4 counts, so the lowest ever CD4 count, they call CD4 nadir, and the risk for cognitive. That's probably the most consistent relationship to immune function so the lower it is, the more chance that somebody could have a cognitive. Doesn't mean they will.
Yeah.
But that relationship. And so that's led people to do studies and think about the earlier treatment. So if you don't, the likelihood of somebody having a cognitive problem when their CD4 count stays above, let's say 500 or 600 for the whole time, because they received early treatment, the risk for cognitive impairments are probably less likely. And so that's a good reason that people are now talking about early treatment, or one of the early treatment benefits to brain. Now, the other part to this is that living with HIV for longer probably causes, we talked about accelerated aging, or the aging piece, is that we're seeing that the mild conditions, that number hasn't gone down at all, but probably going to not increase a lot, but it's still not changing. And I think that's because of just HIV is a significant virus, and the treatments and the things that go along with it are heavy, can be heavy for certain people on their bodies, right? And so I think there is some relationship increasing as people get older. But I think the good news side of that is that when they develop these mild problems, they're probably not going to be it's in that milder condition, not the dementia. And I didn't say this, but the mild, this was often thought that what happens to people when they have this mild neurocognitive disorder, can you develop a dementia? And the answer is probably they're two different things. And so the milder things don't progress usually to dementia unless something medically happens that is very, very significant. And when I started here in Toronto, it used to be, the thought was, we have to lump them all because the mild stuff will just progress, and that never happened. And so CD4 nadir is an indicator. And length may have some relationship, but doesn't mean everybody. So it's a bit of a complicated answer. But thank you so much for your time, and I hope this is helpful. So what is everybody going to do when you go home?
We're going to watch 23 and a half hours.
23 and a half hours. Watch 23 and a half
On
hours.
YouTube.